Welcome to this overview of a new level of care decision tree from your team at Roswell Park. This standardized tool is designed to ensure every patient receives the right care at the right time, in the right setting. This initiative is part of our broader effort to improve value across the system, providing consistent decision-making, determining the appropriate level of care status, supporting cost efficiency with accurate reimbursement, reducing administrative burden from denials and peer-to-peers, and streamlining care, especially for patients nearing end of life. It also supports high-quality care delivered in the safest and most appropriate environment, whether that's inpatient, outpatient in bed, or OIB, community facilities, or home-based care. Every decision begins with a patient evaluation, whether that's in ATC, clinic, on the nursing unit, or after procedures. What does the patient need today, and where can that care be delivered most safely and efficiently? From there, we follow the algorithm. The first question is whether hospital-level care is reasonably expected to span 2 midnights based on medical necessity. If the answer is yes, the patient meets inpatient criteria, as long as medical necessity is clearly documented. If the stay is not expected to span 2 midnights, or if there is uncertainty, we move to the next step. This same principle applies to surgical patients. One caveat is that CMS maintains a defined inpatient-only list, procedures that must be billed as inpatient and automatically meet inpatient status by definition. Next, we ask whether the patient's hospital-level needs are expected to resolve within 24 to 36 hours, meaning they are not expected to span 2 midnights. If yes, this typically indicates OIB. Common examples include hydration, transfusion, pain or nausea requiring brief IV therapy, or IV antibiotics in a stable presentation. Importantly, these patients should be reassessed within 24 to 36 hours. If the clinical picture evolves and the stay is now expected to cross 2 midnights, the patient should be converted to inpatient, and if symptoms worsen at any point, such as instability, worsening vitals, oxygen escalation, or the need for higher intensity monitoring, this immediately shifts the pathway toward inpatient status. It is also important to recognize that, on a case-by-case basis, even if a patient may appear to require only a short stay, certain high-risk clinical factors may justify inpatient admission. In these situations, physician judgment remains essential. The next major pathway involves comfort care and end-of-life scenarios. We ask whether there is a documented or clearly stated intention for comfort care or hospice, and whether the patient's needs are low intensity. Many patients nearing end of life benefit most from maximizing home or community-based support. However, if their needs are high intensity, such as IV pain medication as the only option, high oxygen requirements, vasopressors, or ICU, IMCU level care, they meet inpatient criteria regardless of goals. But if needs are low intensity and they simply require brief hospital-level support, plus logistical coordination, such as optimizing non-IV pain control, arranging comfort or hospice services, setting up durable medical equipment, identifying caregivers, or coordinating transportation, they can remain in OIB while disposition plans are finalized. This ensures compassionate, efficient care while avoiding unnecessary inpatient days. At any point in the process, if the patient becomes unstable, deteriorates, or requires high-intensity interventions, the appropriate status is inpatient admission. Safety always overrides every other branch of the decision tree. There are a few additional points to highlight. When it is determined that the initial inpatient order does not meet criteria and the patient has not yet been discharged, our utilization review team may issue a Condition Code 44, converting the patient to OIB prospectively. This requires a new physician order, and informing the patient, Condition Code 44 protects against payer denials and ensures regulatory compliance. Across all branches of the decision tree, we emphasize early engagement with UR and nurse coordinators, the acute high-risk mortality team, pain and palliative care, social work, and home care or hospice partners. These teams support safe transitions, avoid delays in discharge, and help ensure patients receive the right care in the right setting. Throughout all of this, documentation is essential. Doc-IT means making medical necessity crystal clear using MCG and interqual criteria, the same standards payers use. This includes documenting the patient's severity of illness with objective findings, the specific interventions or monitoring required, the expected time frame, whether observation for 24 to 36 hours or inpatient for 2 midnights or more, the comorbidities that increase short-term risk, why outpatient or OIB care is unsafe today, and the disposition plan along with any barriers. Clear, concise documentation reduces denials, decreases peer-to-peer requests, increases reimbursement accuracy, and protects both the patient and the institution. The level of care decision tree helps us deliver high-value, patient-centered care while reducing variation, improving efficiency, and supporting system-wide alignment. By using this pathway consistently and documenting clearly, we ensure patients receive the safest, most appropriate care with the lowest burden and the best possible experience. Thank you for your commitment to this important initiative and for supporting Roswell Park's ongoing efforts to deliver high-quality, value-based cancer care.